Hello, and thank you for joining me on this discussion about the remission of type 2 diabetes, the user's guide. I'm hoping by the end of our time together that you'll have an appreciation for the answers to the questions of who, what, and how with respect to remission of type 2 diabetes. These are my disclosures. And these are the measures that were taken to mitigate the potential sources of bias. I would like to give credit to not only the names of the people that are on this page who helped write the user's guide, but also to the wealth of reviewers who painstakingly took time to go through the draft document and make their suggestions, which were taken into account and then formed this first published version of the user's guide for the remission of type 2 diabetes. Fun fact, I think that a lot of times we are, many of us, when we're approaching the who should we talk to about remission of type 2 diabetes, many of us are hesitant with how do we proceed. And that was the reason for the user's guide. And I actually wanted to point out that some of the people on the expert working group were chosen because of their degree of hesitation with respect to how do we approach this. And I feel that because we weren't all, 100%, everybody should be spoken to about remission of type 2 diabetes, although there are many that feel that it is our ethical responsibility that now that remission exists, that who are we as clinicians to exert a certain amount of clinician bias, if we were not to speak to that person about remission of type 2 diabetes. So there is a huge ethical issue about how do we approach and who do we talk to about remission of type 2 diabetes. And hopefully the user's guide is going to give us the tools that will make us a little bit more comfortable with conversations with people with type 2 diabetes. An overview of how we set up the user's guide is we have 5 figures that are hopefully going to support conversations that we as clinicians can have with our people with type 2 diabetes. And then we have frequently asked questions, and then we have case studies. And you can see the case studies, we try to have a variety of case studies that were quite practical and quite realistic for who we would be who we would be seeing in our practices. We have the green is go, the green case study of a person that would demonstrate a high potential for remission of type 2 diabetes. We have a yellow case study, which would represent a person in whose circumstances it would be advisable to proceed with caution when considering remission of type 2 diabetes. And we have the red case study, so the one where the person with remission of type 2 diabetes is not recommended. So let's get into it. I'm going to introduce you to Mary. Now, Mary is in my practice, and I'm going to take you through a stepwise approach of what's going through my head as I now recognize that remission is possible for some people, and a stepwise approach of how I handle or how I might be, what the thoughts that are going through my head. I see that she does not have atherosclerotic cardiovascular disease. She does not have congestive heart failure, nor does she have chronic kidney disease. And you'll see that that's green, it's color coded because green means, more likely to, then I can proceed to have that conversation. However, she does have hypertension and dyslipidemia, so caution. Having said that, because she is 50 years old, so under the age of 60, she is not in the high risk populations for which she would benefit from antihyperglycemic agents that would confer cardiovascular and renal protection. So therefore, I can proceed to have the conversation about remission, or that would not be a hard stop of where I would not have the conversation of remission of type 2 diabetes. Okay, what else do I see about Mary? She has been diagnosed with type 2 diabetes 3 years ago, which means she has a recent diagnosis of type 2 diabetes. And we do know that remission is more likely in people with a shorter duration of diabetes, because of the preserved beta cell function. We also know, with respect to the low-calorie diet approach, that the study population had a diabetes duration of less than 6 years. So again, that for Mary, that diabetes diagnosis of within the past 6 years is indicative of green is go. She's more likely to be a candidate for remission of type 2 diabetes. What else do we know about Mary? She has a BMI of 30. Because it's not as high as hitting the cut point of 35 or higher, I'm possibly in my head considering, if I was going to have the conversation about remission of type 2 diabetes with Mary, I might advise her, instead of going through bariatric surgery, I might advise her towards more the low-calorie diet approach. Her A1C is 8.0%, which is less than 12%. It is indicative of someone who met the study population that showed that people were able to get into remission of type 2 diabetes. The other thing I'm noticing about her is that the current medications she is not on insulin. And again, that also met the criteria for the study population. And because she's not on insulin, when I refer back to this graph, it does imply that she has preserved beta cell function because she hasn't needed insulin yet. So now that I've established that anti-hyperglycemic agents are not indicated for Mary based on the need for cardiovascular or renal protection, I can proceed to have the conversation about remission of type 2 diabetes with Mary. And I'm going to open up this tool with the 5 A's adapted for remission of type 2 diabetes. And I'm going to start by asking permission to discuss remission of type 2 diabetes. And remember, I was saying how some of the questions I wanted to be able to answer are the who, the what. So what is remission? These are some of the things I could discuss with Mary. I could discuss to let her know that remission is not a cure, but that it more reflects an often temporary resolution of hyperglycemia without anti-hyperglycemic medications. And so you can see these are kind of this, you can see how this could help or hopefully help support some of the conversations I could have with Mary. I could then move on to assessing Mary. You can see that we've already discussed some of the biomedical factors that have gone through my head before I even possibly started the conversation. But the other one that I wanted to point out in the 5 A's is this one. And if any of these conditions do exist, it's not necessarily a hard stop. It's more a matter that I would want to make sure that I addressed them in conversations with Mary and made sure that Mary is receiving the proper support for the other concurrent conditions. And further within assess, you could use the shared decision-making checklist for remission of type 2 diabetes to support conversations as well. Now, they are designed to be separate standalone tools, and so you will see that there is overlap between the information that's on this page with the 5 A's. But the shared decision-making checklist was designed to give that balance, to support conversations that remission of type 2 diabetes isn't necessarily for everybody. So I'm just going to draw your attention to the 3rd section to let people know that there's not enough current evidence to understand how remission of type 2 diabetes compares to staying on diabetes medications, particularly the medications that support weight loss and have proven heart and kidney protective benefit in selected populations. Another thing that we wanted to make sure that we have conversations about is that there's not enough current evidence to understand the impact or sense of failure if remission is never realized, despite the effort, or if a remission occurs followed by relapse of type 2 diabetes. There's actually not enough evidence to understand the level of expertise that healthcare professionals require to support people with type 2 diabetes with respect to movement into, during, and out of remission. And I think that's important because the remission is new, and we're all working on increasing access to care, access to the potential of remission. And then I'd like to draw your attention to the last section, which I thought had a couple points, well, had several good points, but the couple points that I wanted to bring to your attention was that even if I don't arrive at remission, through the process of remission with modest weight loss, which was defined as approximately 5 to 10% of initial body weight, I could have substantial improvement in my insulin sensitivity, blood pressure, cholesterol, and improved management of glycemic targets. And that I understand that there is evidence that shows the effect of stigma associated with body weight and type 2 diabetes, and I have a right to care that is free of discrimination, racism, and oppression. And the idea of that bullet point was to try to encourage, open up those conversations with the people that we are caring for that are affected with type 2 diabetes, and allow them to let us know how they're feeling, and to make sure that we are doing our best to recognize if there are feelings of stigma present, and doing our part to sort of neutralize those feelings. Okay, so returning to the 5As, after we finish our assessment, we could move on to advising on management. And you'll recall that Mary's BMI of 30 might cause us to lean more towards the low-calorie diet approach should Mary be interested in remission of type 2 diabetes. And so you can see we have a tool called the low-calorie diet for remission of type 2 diabetes. And this is adapted from the direct trial. And you can see on the very bottom left that it reinforces or reminds us as clinicians who was the study population that was used in the direct trial. You'll also note that the direct trial is a UK trial, and so we adopted that for what we have available to us in Canada. And on the very top, you'll see that we really tried to emphasize that this approach requires a substantial commitment to engage in a prolonged health behavior intervention, and that after a year following this approach, almost half of people were in remission. And at 2 years, even fewer people were in remission, which just emphasizes the substantial commitment required and the need for timely follow-up to stay in close contact with the healthcare professional. And then because we adapted the direct trial for the Canadian population, you'll see in phase 1 and phase 2 where shakes and soups are recommended. In the subsequent table, you'll see that we have on the left-hand side, you'll see that we have the meal replacement shakes that are available in Canada and the suitable soups that are available in Canada. And on the right-hand side, when in phase 2, when we start reintroducing foods, we've come up with examples of meal planning. And after we advise on management, we can agree on the plan and then assist with drivers and barriers. And what we really wanted to emphasize is the timely follow-up that is necessary to determine the need for evaluating the plan and possible relapse management. The word timely was used to reflect that would be very much individualized based on the amount of support that person needs, possibly could involve the commute that's involved in getting to your office and things like that. So summarizing Mary with shared decision-making, she is on metformin 500 milligrams orally twice daily. And because of the low risk of hypoglycemia and weight gain that is associated with metformin, in this case, we decided to continue metformin initially. With respect to the perindopril 4 milligrams daily, I'll remind you that Mary is 50 years old, so she's less than 55. And again, recall that we would consider an ACE or an ARB for cardiovascular protection at the age of 55 years old with the presence of a cardiovascular risk factor. So because she is actually less than 50, we do not need to consider whether she needs an ACE or an ARB for cardiovascular protection. And because Mary's blood pressure is at target, therefore we can actually discontinue the ACE or the ARB for Mary. What about the statin? So Mary is 50, which means she's over the age of 40. And so even if her cholesterol levels are at target, we are going to continue the statin for cardiorenal protection. Mary has a sedentary lifestyle, and as indicated and as written in the low-calorie diet tool for remission of type 2 diabetes, we would not increase physical activity during phase 1 of the low-calorie diet, but that we would then consider phasing that in, and we would address that further on in her management plan. So let's move on to Farah. In Farah's case, Farah actually has come into the office and she's asking me,
is remission appropriate for her?
So I then can use my 5A's tool and I can use some of these bullet points to support the conversations. But what I'm doing here then is, instead of using this shared decision-making checklist in the assess, I'm just bringing it right in earlier under the ask. But I will then go on to do my assessment of Farah. So Farah does not have end organ disease, and although she does have hypertension and dyslipidemia, she is under the age of 60. So therefore, the anti-hyperglycemic agents that confer cardiorenal protection are not indicated as yet for Farah. So I can proceed to have the conversation about whether we could stop all anti-hyperglycemic agents and go the route of remission of type 2 diabetes with Farah if she should be interested. Farah was diagnosed with type 2 diabetes 10 years ago, and that is highlighted in yellow, so proceed with caution. But it's certainly not a hard stop at all. Although it's beyond the 6 years diabetes duration that the study population used for the low-calorie diet approach, it certainly is applicable for bariatric surgery. And when you speak to clinicians who have supported people in remission, they have had people get to remission with the diagnosis of 10 years or beyond even. What else do we know about Farah? She has a BMI of 42 and an A1C under 12, which again suggests or indicates that we could continue to have a conversation about remission of type 2 diabetes. Farah is on insulin, which is not a hard contraindication, but it is something that makes me think possibly that maybe she's further along in her beta cell decline. Again, not a hard stop, but it's just something to consider. And I'll introduce you to another tool that we created, the COM-B model, which tells us that the behavior in the center is a result of capability, opportunity, and motivation. And I'm hoping you can see how you could use this tool to reduce the feeling that many people have that possibly I am not achieving my desired behavior because I lack motivation or whatever it is. The idea is to really try to figure out what domain needs supporting to allow that person to achieve the behavior that they're aiming for. And I'll give you a small example. If, for example, many times socially, a lot of our social activities are eating, and social activities are important, as we know. But if it's always around eating, then possibly we're going to have to make sure that our social influences are supporting our behaviors. And again, this tool might support those kinds of conversations and supporting then what kind of foods I need to have in my social settings. So we've done our assessment and we can move on to advising on management. And in this case, maybe we are going to proceed with referring Farah to a bariatric surgery program.
And then we're going to agree on a plan and then look at
what are the other considerations for Farah. Farah is on insulin, and so we could add a GLP-1 receptor agonist and reduce the insulin by 20%. And we would also let her know that if she were to experience hypoglycemia, that we would want her to reduce her insulin further. And what about the perindopril and dapamide combination? You will recall that Farah is 55 years old with hypertension and dyslipidemia, and her blood pressure is at target. So the question is, does she still need the ACE inhibitor? I'm going to draw your attention to the quick reference guide and point out to you here, when we have somebody who is over the age of 55 with additional risk factors, and you can see on the bottom there that in this case, Farah does have hypertension and dyslipidemia at this time. And so following the arrow, we would keep her on the statin and the ACE at this time. And I'll also bring your attention to the second footnote there, that the ACE or ARB that we use should be given at doses that have demonstrated vascular protection. So in this case, perindopril 8 milligrams as per the Europa trial. So going back to here, what we could do then, because her blood pressure is at target, and we don't want it to go too low, we could stop the indapamide, the diuretic, but we would want to increase the ACE, so the perindopril, to 8 milligrams daily. And the rosuvastatin, as I had shown you, we would want to continue the statin for cardiorenal protection. Okay, so now we've reviewed the user's guide with respect to introducing the various tools that are designed to support conversations. We've talked about 2 cases. We had Mary, who was a green case that showed a high potential for remission of type 2 diabetes. We had Farah, who was more proceed with caution, but certainly in this case, there was no contraindication. We could proceed to have conversations about remission of type 2 diabetes and assess Farah's interest in that. But we had a lot of questions about where does remission of type 2 diabetes fit into the overall management of type 2 diabetes? And I'm going to use the quick reference guide panels to hopefully show you the consistency within the Diabetes Canada guidelines. And that is that the first thing we do is we assess whether the person would benefit from staying on that anti-hyperglycemic agent that has demonstrated cardiorenal benefits. So we'll ask ourselves, does the person have end organ damage, or is in that high-risk population? And if so, then we would keep them on those agents, and remission is not recommended for them. And so once we've cared for the need for cardiorenal protection, we can then look at the person's individualized A1C target, and through shared decision-making, we can determine which is the most appropriate way in which they would like to manage their diabetes and how they would like to get to their A1C target.
We then took the A1C targets table that you're probably very familiar with and expanded it to include the option for type 2 diabetes remission, wherein adults who have an A1C between 6.0 and less than 6.5 have the potential for remission to prediabetes, whereas somebody who has an A1C of less than 6.0 has the potential for remission to normoglycemia.
I hope that in spending the last few minutes together, that this has built your confidence in supporting people with type 2 diabetes in remission, if that's their wish and if it is so appropriate for them. But I hope that this isn't the conclusion of any kinds of conversation. As you can imagine, remission is new for all of us, and we are continually learning from each other and wanting to build our tools and then create things that are effective and helpful. So I encourage us to continue the conversation through community.diabetes.ca. Through community, you can go to the community forums and you can put up a posting, and that would then encourage the whole membership to learn from each other. You can also ask a question, or you can contact us, and the dissemination and implementation team, we're constantly looking for ways in which we can improve our tools. So we do value your feedback and all your suggestions. In the words of Mindy Kaling, I hope that I have earned the privilege of your time. Thank you.